your kisses make it go. Neon, 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 let me let me let me let me neon, neon, neon.
For there is a zombie apocalypse currently happening on the West Coast.
Another day, another case to ace.
If any zombies happen to get into your house,
Brown out na naman!
I don't wanna go home today. You don't really wanna just go.
Good morning to the present. Morning to the present.
I think I might just leave. Sing a little louder, get me a little higher, so I can just dance with you.
To the classics.
Good morning, class.
Good morning,
Good morning, po, Doc.
Morning, Doc.
So, please turn on your camera so I can see you. Good morning, and I would like to congratulate everyone for reaching this part of the semester. With that, I would like to present a case to integrate or share all the concepts that we have discussed. Our activity today is going to be exciting. So with that, let me share my screen.
A 33-year-old, 30 weeks pregnant housewife was brought to a local clinic almost comatose during the monsoon season. She was referred from a local clinic after 6 days of treatment of severe diarrhea. She presented with vomiting and loose bowel movement that started with 3 to 4 episodes of vomiting and 3 to 4 semi-solid stools per day. This gradually progressed to profuse watery diarrhea of 20 to 25 bowel movements per day resembling rice water. She had decreased urine output for the last 3 days but did not complain of abdominal pain or fever. Her skin appeared shriveled, and when a fold of skin was pinched, it remained so for several minutes. The patient was dehydrated, unable to stand, and was lying in bed with dry skin and sunken eyes. Vital signs: pulse 120 per minute, blood pressure 90/60, temperature 37.7 degrees Celsius, respiratory rate 20 per minute. The fetal heart rate was 156 per minute. Okay, mommy, let's take your vital signs and do some laboratory tests. It shows that the laboratory investigations are consistent with dehydration. However, the stool examination showed presence of unusual bacteria. Can you recall the things you ate for the past 24 hours?
Let's see. Well, I ate my usual vegetables and fish at a local cafeteria.
Okay, we need you to stay here for further observations, mommy, to ensure your and your baby's health.
So given the symptoms presented, what do you think is the causative?
As stated in the case,
patient experienced episodes of vomiting and rice water diarrhea, which is the pathognomonic for cholera. And this is caused by the causative agent Vibrio cholerae. This was confirmed in the stool examination, which revealed a highly motile, comma-shaped and gram-negative bacteria. And the most probable cause for this is that the patient might have ingested this agent through contaminated food or drink.
Yes, you may be right. Assuming that she really had ingested contaminated water, can you elaborate on how the contamination affected her?
What happens, Doc, is that the bacteria binds to the small intestinal wall to release the cholera toxin.
Haha! Let's invade this nutrient-rich wonderland!
Yes. Let's ribosylate the alpha subunits of stimulatory G proteins so we could cause some serious damage.
Oh no! There are toxins trying to attack us!
Please, have mercy. Don't catalyze an ADP ribosylation of my alpha subunits or else there will be serious consequence.
Mercy? That's not in my vocabulary. Ha! Danger is my middle name.
Hey bro, I think there's something wrong. We are being activated more than usual.
Yeah, I know, dude. Sodium chloride keeps on coming and coming. What's going on?
Hey! Ion transport channels! What are you guys doing? There's too much sodium chloride influx. I cannot handle all of these.
Sorry boss. We don't know what's happening either.
So yes, thank you, Miss Gana.
Oh, also, Doc, due to the accumulation of sodium chloride in the lumen, a consequent loss of electrolytes and fluids was experienced by the patient, resulting in a cascade of symptoms. So this resulted in the isotonic dehydration, which caused the patient to have shriveled skin and sunken eyes. So, yeah.
So do you think that dehydration was the only consequence of that event?
Doc, with the loss of bicarbonate and blood, the blood of the patient had become acidic, which in turn stimulated the nucleus tractus solitarius, which sends signals to the chemoreceptor trigger zone to the vomiting center, Doc. And this explains the vomiting episodes experienced by the patient. Additionally, the loss of electrolytes and fluids cause a disruption in the normal neuronal metabolism, resulting in a near comatose state of the patient. So she had become hypotensive with a BP of 90/60 due to the decrease in blood volume caused by the loss of fluids and electrolytes. And similarly, Doc, the renal blood flow has decreased, causing a lower GFR, which produced a hyperosmolar urine, which was decreased in output.
Doc, so the Vibrio cholerae release cholera toxin which attack the immune system, causing the release of cytokines that can cross the blood-brain barrier and eventually reach the organum vasculosum laminae terminalis, or the OVLT, located at the preoptic nuclei and anterior hypothalamus.
So what if the cytokines reach the organum vasculosum?
The OVLT releases prostaglandin E2, which travels to the posterior hypothalamus. The hypothalamus, being the temperature regulator center, is stimulated to increase in temperature set point from the normal body temperature of 37.5 degrees Celsius. This increase is the one causing the patient's fever.
You're right, Mr. Landicho. Could you also explain the other symptoms?
So I think Doc, the loss of bicarbonate led to the decrease in blood pH, which led to metabolic acidosis. So to compensate for this metabolic disorder, the patient will hyperventilate. Due to the low blood volume, the patient will also have low blood pressure. So venous return will decrease, leading to a decrease in end diastolic volume, and will decrease also the stroke volume and ultimately the cardiac output. So with this, the patient will have low aortic pressure and would be sensed by your baroreceptors in your aortic arch and your carotid sinuses. And as a compensatory mechanism, there will be a decrease in baroreceptor firing to the medulla that would stimulate the sympathetic response and would inhibit the parasympathetic tone. So this will lead to a increase in heart rate that is manifested by our patient.
How about the medications? Why do you think were they prescribed?
Isotonic sodium chloride was given to correct the loss of electrolytes and fluids brought about by the excessive vomiting and passing of stool of the patient. Doxycycline is the drug of choice for pregnant women intended to act by binding to the 30S prokaryotic ribosomal unit of the Vibrio cholerae bacteria during its protein synthesis, thus inhibiting its replication.
So that was very comprehensive, Mr. Landicho.
Few hours after admission, she became breathless and severely hypotensive. The doctors cannot detect her arterial blood pressure, the pulses were weak and rapid. She was also tachypneic and extremely dizzy. Her extremities were cold and clammy, the conjunctivae very pale, and she appeared delirious. The fetal heart rate rapidly deteriorated.
So Mr. Landicho explained how the patient compensated. She was also given IV fluids to restore her blood volume. With that, how come she is still hypotensive, has weak and rapid pulses, tachypneic, dizzy, delirious, has cold and clammy extremities? Can anyone tell me how?
Doc?
How about the others? Mr. Landicho, why are you laughing? Can you tell me the mechanisms on how the patient is compensating?
Doc, sorry. But I think, Doc, there might be something wrong with the patient's aldosterone production po.
And what made you say that? Can you support your claim?
Doc, since the patient was given isotonic fluid, the blood volume is expected to increase through isoosmotic volume expansion. But in our case, the patient was still hypotensive with weak pulses. With the decreased sodium chloride sensed by the macula densa, renin would be released. However, due to the decrease in aldosterone production, the effect of RAS, which is to increase blood pressure, is not magnified enough, Doc.
So, good idea. Is there someone who would like to continue or add to what Mr. Landicho shared? Miss Pelobello, anything you'd like to add?
Doc?
We cannot hear you, Iha. Can you please speak up louder?
Okay po, Doc. So, Doc, since the patient had severe hypotension, it also led to a decrease in the perfusion to the organs po. So this is, Doc, sorry.
It's alright, Iha. Go on.
Okay po, Doc. So, so in addition po to the patient, she was experiencing dizziness. So she presented also with a very pale conjunctiva due to the decrease in the blood flow to the ophthalmic artery. So, similarly, the decrease in perfusion is what caused for the baby to be in distress. So, as the blood supply was decreased to the placenta, and this resulted in the baby to experience a rapidly deteriorating fetal heart rate.
A central venous pressure catheter was inserted and recorded a pressure of less than 1 mm mercury. Fluid resuscitation was performed with lactated Ringer solution at an initial bolus of 2 liters and continued at 500 milliliters per hour. The doctors decided to perform an emergency cesarean section. A viable fetus weighing 1.2 kilograms was delivered with an APGAR score of 1 and 6 at 1 and 5 minutes respectively. 12 hours post-op, the patient's arterial blood pressure had stabilized and respiratory status was normal. When she was fully conscious, she was given a rehydration solution to drink that contained glucose, sodium chloride, potassium chloride, and sodium bicarbonate. Her stool frequency decreased. However, her urine output was still very low at 10 milliliters per hour. According to the blood tests, calcium, serum creatinine, BUN, and glucose were elevated.
So, can anyone interpret the blood test result?
Doc, rinig po ba ako? She was given an oral rehydration solution that contained glucose, sodium chloride, potassium chloride, and sodium bicarbonate. This would correct her electrolyte and fluid imbalance caused by the dehydration earlier. However, the patient still had low urine output due to the low blood volume, causing her low blood pressure. This provides hyperosmolar urine to conserve her fluids. She is hyperglycemic and with elevated levels. Connected.
Hello? Miss Baidiango? Hello? Maybe she got disconnected. Hello? Miss Froyalde, would you like to continue interpreting?
Doc, I think what Miss Baidiango was trying to say is that the patient
I found a new place to go. Made up my mind and so I'm leaving.
says that the patient had become hypercalcemic and hypoglycemic with elevated levels of creatinine and blood urea nitrogen. This supports what Eliah mentioned earlier, that she might have an acute kidney injury. Since the kidney's function was impaired, it cannot properly secrete these waste products anymore. Also, due to the patient's hypotension, blood flow may also be decreased in the pancreas, causing less production of insulin. With low insulin levels, there would be no glucose uptake and utilization. Glucose would tend to stay in the blood, leading to the patient's hyperglycemia. I have also read that the pregnancy and lactation may cause pseudo-hyperparathyroidism. As the PTH is increased, so is the concentration of calcium in the blood as produced by the breast during lactation. Additionally po, dehydration may also cause a mild increase in the serum calcium, and with the decrease in fluids, increasing the concentration of calcium in the blood, hence resulting in hypercalcemia.
The next day, she became breathless again. She also developed dependent edema. She was very weak and confused. Her blood pressure was 150/90, pulse rate of 121 per minute, and respiratory rate of 28 per minute. She had an S3 heart sound and +3 pitting bipedal edema. Fine crackles were heard over the lung bases. Laboratory tests at this point showed that BUN and serum creatinine were still elevated. ABG results showed pH of 7.09, carbon dioxide and oxygen pressure of 12 and 135 millimeters mercury respectively, and bicarbonate concentration of 3.6 milliequivalents per liter.
So can anybody please interpret the ABG results? Remember, blood tests are important because they give us a clinical picture of the patient.
Doc, the plasma creatinine and BUN was elevated more than 3 times from the previous lab results po. ABG also shows a low pH, low bicarbonate, and low PCO2, indicative of metabolic acidosis with an elevated ion gap of 33 and is compensated by her respiratory rate that decreased her PCO2. Aside from that, her PO2 was also elevated. Since kidney injury was suspected and low urine output was evident to the patient, fluid backflows into the circulation. There is a great sodium and water retention that increased the hydrostatic pressure and led to the edema of the patient. Also po, with the fluid overload, blood pressure, pulse rates increase, leading to an increase in LV-EDV, tension generation and LV dilation. LV compliance increased. Prolonged increase in tension resulted to an increase in myocardial fibers that led to the hypertrophy of LV, decreasing its compliance, thus hearing S3 sounds during early ventricular healing.
The patient was treated aggressively and closely monitored. Sodium bicarbonate was administered and she was given furosemide. Restriction of salt and water intake was strictly observed. The patient improved dramatically after initiation of hemodialysis. After 10 days, the patient had recovered sufficiently to leave the hospital. Just when the doctors thought that they never see the patient again, one benign afternoon, the patient showed up again due to nausea and vomiting. According to her, she has been feeling like this intermittently since 2 days prior to coming to the hospital. She felt tired all the time. She suffered from lightheadedness, palpitations, cold sweats, tingling of the lips, trembling, and weakness. Sometimes, she also failed to eat on time. Her baby was bottle-fed because she was unable to lactate after delivery. She also had prolonged amenorrhea. The doctor reported she was sick-looking, thin, with sunken eyes. Her pulse was 98 per minute and blood pressure was 90/70 on supine but dropped to 70/55 on sitting up. The skin was pale with absence of hair from skin, axillae, and groin. Examination of the lungs, heart, and abdomen were normal. Examination of the central nervous system revealed generalized muscle and fat wasting and delayed relaxation of the ankle reflexes. The remaining examination was normal, including fundoscopy. Investigations revealed hemoglobin of 10.7 and hematocrit of 29% with normocytic normochromic red cells. Total white cell count was 6,000 per microliter with a normal differential count. Blood chemistry showed that the patient has low sodium, low hemoglobin and hematocrit, low BUN, and low glucose. Serum osmolality was 220 milliosmoles per liter, and the urine osmolality was 618 milliosmoles per liter. A hormonal disorder was suspected and confirmed by hormonal level determination with very low hormone levels of cortisol, FSH and LH, prolactin, estradiol, TSH, free T3, and T4.
MRI of the brain showed a normal size but empty sella turcica. The diagnosis was established and the patient was started on hormonal replacement therapy. I'm sorry, can you please speak up louder?
Doc, I think she's asking if the case is now closed.
Guys, I don't think so.
Yay! Case closed!
You got disconnected again, didn't you?
Anyway guys, Anne was right. The case doesn't end here because 5 years later, the patient went back again because of an abrupt onset of a lower back pain.
An ER doctor from 5 years ago recognized her and took her history, which included significant findings of excessive weight gain over the past 3 years, easy bruising, muscle weakness, and increased hair growth in various areas of her body. She mentioned that she had bouts of euphoria and depression. As if the patient wasn't suffering enough, she added that her sleep was also disturbed. This was despite the fact that her cute baby girl, 5 years old at the time, was so good to her, behaves at night, and even helps her carrying groceries when they go to the market.
So by now class, you're probably getting an idea where this is going, don't you?
Yes, Doc. I think there's something wrong with your endocrine system.
And what made you say that?
Excessive weight gain, increased hair growth, emotional lability. It's got to be her endocrine system, Doc.
To add to what Marco said, Doc, I've read that corticosteroids cause daytime jitters, insomnia, and decreased REM sleep. It actually makes sense since the patient was started on hormonal replacement therapy 5 years ago. But isn't that supposed to be good for the patient? After all, it's therapy.
Right. 5 years ago, she was prescribed to take levothyroxine and estrogen on top of cortisone 25 milligrams. After some time, cortisone is shifted to dexamethasone 0.5 milligrams. But this is where it gets interesting. When the patient started to feel weight gain, when she took dexamethasone, she decided to take it 8 times more than the prescribed dose. I repeat, 8 times! So she took 4 milligrams of dexamethasone instead of 0.5 milligrams.
The widespread delivery of hormones in the blood allows the endocrine system to perform its different functions in the body, which includes development and growth, maintaining internal homeostasis, and regulating the onset of maturity. Given that hormones play these vital roles, of course, it is important for them to be kept at their respective normal plasma concentrations. Endocrine diseases can be caused by a number of reasons, among which is the presence of hormones in excess, like what we have seen on the patient, since she took more exogenous hormones than prescribed. As a result, hypercortisolism, termed as Cushing's syndrome, came about.
OMG! Look at all these adipocytes!
I know, right? Let's make some friends.
I'm so excited, and I just can't hide it.
And so, dexamethasone 1 made a friend.
Hi! You know what? I think you should totally turn to glucose.
You really think so?
Of course! You have so much potential!
And so, the adipocyte, inspired by dexamethasone's words, pursued a gluconeogenic pathway.
OMG! Hi, friend! Can I tell you something? Okay, so hear me out. I think this body's fast and wide, and you should be free.
OMG. You know what? I think so too. I've been wanting to explore a relocate for some time now. Thanks, friend.
And so, after the interaction, adipocyte 2 as well as a few of her friends underwent beta oxidation. Adipocyte 2 and friends eventually became free fatty acid. With freedom, some of her friends decided to settle in the face and some above the clavicle. Adipocyte 2 herself decided to settle down about the trunk where she met new friends.
The patient was an obese woman at the time of PE with excess adipose tissue in the face, above the clavicles, and about the trunk. This was the manifestation of how the glucocorticoids influence adipose tissue mobilization. It came to a point that so much adipose tissue settled on the abdominal area that it stretched the patient's skin, resulting to purple abdominal striae. Wait, I'll show you a picture. Do you guys see the picture? Okay.
Doc, how about the patient's total cholesterol and the triglycerides? Are they not supposed to be elevated too?
Good question. With that, let's continue.
Some of adipocyte 2's cousins, cholesterol and triglyceride, decided not to settle and take their sweet time in the blood.
OMG, isn't that the liver? I've only read about this in books.
Traveling is so fun.
Oh my god. Look at that muscle.
How are you doing?
We're here on the field trip, and you're our second stop.
That sounds fun. Feel free to interact with my receptors.
Hi! It's great to finally meet on my side.
Nice to meet you too. Check these proteins out.
They look great, but have you tried going back to basic?
And so, the myocyte, influenced by dexamethasone's words, decided to break itself down to its basic amino acid components, which eventually pursued a gluconeogenic pathway. As they were about to leave the muscles for their next stop, the dexamethasone molecules spoke to each other about their experience.
Elias decided to go back to basic today because of me.
I actually told a myocyte not to translocate GLUT4 to its membrane. I wish I could take it back. Because of me, that myocyte is now resistant to insulin. How are they supposed to get glucose now? This is all my fault.
The patient's free fatty acids were mobilized, so it follows that leptin release would be decreased. As an effect, there would be decreased stimulation in the satiety center, to which the body responded by increasing appetite. And also, remember that there's starvation of the skeletal muscles since glucose cannot enter its cells due to insulin resistance. This muscle starvation could stimulate the release of neuropeptide Y, an orexigenic hormone that can increase the patient's appetite.
The journey continues for the glucocorticoids as they make their way to the embryonic mesoderm tissue.
Dexa?
Hi friend, don't you think it's time to give differentiation a rest? Rest is important, you know.
I guess.
And so, the embryonic mesoderm tissue did not differentiate into a fibroblast that day.
Do you wanna build some collagen?
I think you should rest too. I shouldn't see you anymore. Go out the door. Collagen production can wait.
Okay, bye.
Glucocorticoids have an inhibitory effect on collagen and fibroblast formation. As a result of this, the skin thinned and easy bruising was observed as collagen is an important connective tissue which supports the capillaries.
While on their way, dexamethasone saw estrogen and levothyroxine walking.
Hey guys, wake up! Where are you going?
To the brain.
The brain? Can I come with you?
Yeah, sure. Come on.
Hey glucocorticoid receptor, let's bind together.
Hop on!
Glucocorticoid receptor, inhibit THP2.
Oh no!
After dexamethasone has successfully inhibited DHP2, levothyroxine converted itself to L-iodothyronine to start its action.
I will bind to thyroid receptors and enter the brain via transthyretin. Hypothalamic TRH, activate!
Activated!
And then to finally complete the action, estrogen joined the fun.
Serotonin 1A, lower down your expression.
Oh no!
The three hormones caused the lowering of serotonin levels inside the patient's body that caused for her depression. But wait, there's more.
Our work here is done.
No, I'm not done yet. I need to elevate the cortisol level of this patient to keep her awake.
Hey, nice.
Now we're done. Okay, bye fellas. I need to go to the heart.
So dexamethasone continues their adventure towards the heart, and upon arriving,
Alpha 1, Beta 1, expression increase. Catecholamines, increase. Okay, now, group 1 of catecholamines bind to Beta 1. Then, group 2 of catecholamines bind to Alpha 1.
Oh, wait, what? Why am I constricting? Ah!
the dexamethasone increased the expression of beta 1 and alpha 1 to increase the production of catecholamines. This in turn caused for the constriction of the heart, which increased its stroke volume and cardiac output, and eventually caused for the patient's hypertension. Since the patient became hypertensive, the blood rushed to the kidney. So let's see what happened to the kidney.
Hey man, I have a high pressure, so you should also increase your filtration rate.
Oh, sure.
Hey Dexa, what are you doing here?
I am here to increase your ammonium production to also cause hypokalemic alkalosis. Ammonium, increase your production so you can enhance the production of blue bicarbonate.
As the glomerular filtration rate has increased, this will cause for the subsequent increase in its tubular fluid flow rate, in which both the sodium-potassium ATPase and potassium permeability will also increase. Along with this, dexamethasone also increases ammonium to enhance the production of new bicarbonate. The end result of this is the urinary excretion of potassium, which is presented in the patient as hypokalemic alkalosis. From the heart, dexamethasone arrived in the eyes and saw estrogen.
Oh hey there, Dexa, you're also here.
Yes, I will be focusing on altering the transcription of gene through activating my glucocorticoid receptor. How about you? What will you do to develop cataract in her eyes?
Oh, I will just increase the C-reactive protein or CRP, and that will lead to the development of cataract.
Really? Why the CRP?
Yeah, because CRP is a major acute phase reactant that is markedly elevated in inflammatory conditions. So when we have systemic inflammation in the body, this will cause oxidative stress to the cells affecting the eye, which results to a cataract.
Wow, that's so cool!
I know, right? How about you?
Oh, you know, I will just alter the transcription of the gene. This alteration will also cause an uncontrolled proliferation of epithelial cells in the eye, leading to the development of the cataract.
That's also very promising. Okay, let's do it!
Given the things that you've learned in the past months, what would you do next? How would you manage the patient? Ella?
Well, Doc, since the patient was complaining of lower back pain, she should be given analgesics to relieve her pain first.
Let's not forget that she was also suffering with hypertension with a BP of 180/110. And along with this, her urinalysis showed a 3+ glucosuria, and her fasting blood glucose is at 180 milligrams per deciliter, which is very high considering that the normal plasma glucose is at 100 to 125. So in line with this, she should be prescribed to take antihypertensive and oral hypoglycemic agents.
Doc, also, I think that the patient should also be advised to go on a diet and then exercise and physical therapy, since her physical examination showed that she's obese and she also has excess adipose tissue largely in the face and then above the clavicles and about the trunk.
Yes, that's right. But unfortunately, the patient wasn't able to comply to the prescribed therapy.
Over the next months, she still complained of low back pain and insomnia. She also reported increased thirst and excessive appetite. There was also increased urinary volume and marked weakness, together with burning and tingling sensations in a stocking glove distribution.
1 year later,
Where should I go next? Hi interleukin 1, I am Dexa. I am here to tell you that you will not produce cytokines even with the presence of invading microorganisms.
But how about our immunity? Isn't it important too?
It doesn't matter. Also, tell interleukins 2 and 6 that they will not be used too.
Streptococcus pneumoniae found an opportunity to proliferate by invading one's body.
Whee! Another day, another body to infect.
Wait, I can sense that there is a microorganism inside our body.
But remember what Dexa told us?
Oh!
Can someone please elaborate how did the patient contract a respiratory infection and discuss the development of the disease?
Hello po, Doc. Can you hear me po, Doc?
Yes, please go on.
Doc, the corticosteroid is a known immunosuppressant, and this makes the patient at risk for opportunistic infections like the pneumococci.
And so to add to that, Doc, upon entry of the pneumococcal bacteria in the airways, it travels towards the alveoli and proliferates there. And since there are still antibacterial defenses of the body, this produces inflammation in response to an invading microorganism. So there will be alveolar inflammation. And then the presence of microorganisms as well as the excess sputum in the airways stimulates the receptors in the airways and sends signal to the CNS via the vagus nerve. And then the CNS stimulation triggers a release of neuropeptides in the C fibers. And then the neuropeptides stimulate the production of substance P, and this irritates the cough receptors in the medulla and manifests as the patient having cough episodes.
Yes, and also, Doc, inflammatory mediators in the alveoli increases the capillary permeability, which leads to fluid field shifting. So this is also expected that the patient would have fluid in the lungs and would show infiltrations upon X-ray.
Okay, that was a very good discussion. Yes?
Can I add something, Doc?
Sure, go on.
Okay po. So, it is also important, Doc, I think, to mention that the patient will manifest an increase in respiration in order to compensate to the decrease in air exchange and ventilation in the alveoli due to the fluid accumulation. As Eliah mentioned earlier, there is a fluid inside the alveoli, and this happens to wash and lose surfactants present in the alveoli. And we know that surfactant is an important to decrease the surface tension. With the increasing surface tension, transpulmonary pressures increases, thus decreasing the lung compliance. This decreases ventilation and in turn decreases the oxygen that enters the alveoli. Upon the activation of the peripheral chemoreceptors, ensues and stimulates the respiratory centers in the VRG and DRG, which send signals to the respiratory muscles to increase the rate of respiration, which is now manifested in our patient having tachypnea po.
Okay, that was very good, Mr. Landicho. Thank you for that comprehensive discussion. So going back to the case, the attending physician of the patient requested for routine CBC with peripheral blood smear, and when the blood results came back, it showed leukocytosis and lymphopenia, as well as increased RBC count with normal platelet count. Can you correlate these results with the said infection? Any other students? Okay, Anne.
Okay, po, Doc. So, the patient had taken large amounts of exogenous glucocorticoids, and this type of drug represses the production of lymphocytes. That's why the blood exam showed decreased levels. And there was an increase in neutrophils, on the other hand, because of the presence of infection, which is the causative factor of pneumonia. And I think this patient is given antibiotics in order to help the body fight against the infection. And for the increased RBC, this, I think, is a compensatory mechanism of the body because of the decreasing oxygen pressures in the blood secondary to ineffective gas exchange.
Since we have a problem in oxygenation due to the presence of fluid in the alveoli, oxygen pressures in the blood is decreased. This decrease in oxygen saturation is detected by the glomerulus of the kidneys, thus producing erythropoietin. This erythropoietin stimulates the red bone marrow to synthesize RBCs to help increase the oxygenation.
That was well explained. Thank you, Miss Gana.
I think I want to go to the bone matrix. Okay, let's go to the bones. Hi, Bone. We meet again. How are you?
I'm getting tired. My body's getting heavier and heavier each day. I can't perform my usual activities.
I'm so sorry to hear that. But guess what? I'm here to talk to your osteoblast. Can I come in?
Okay.
Osteoblast, I'm here to tell you that you will be stopped from producing more of yourself. And can you please release rank L and CSF for me?
No, I won't do that. My body is getting heavier, and by doing that, it would make me weaker and more fragile.
I think you have no choice.
Okay.
Hi, Osteo class. We're here.
But why? Aren't we getting weaker? If we do this might cause fractures.
We have no choice. This is as per cortisol's orders.
Okay. With this in mind, what do you think might happen next? Miss Froyalde, can you please answer this question? Hello? Miss Froyalde?
Doc? Yes po, Doc. Can you hear me po, Doc?
Yes, please continue.
Okay po, Doc. I think, Doc, the patient is at risk for fractures and eventually osteoporosis later in life. Occurrence of fractures can be explained due to the progressive decrease in the integrity of the bone matrix because of the degradation. Added up with increasing weight of the individual, patient is prone in developing pathologic fractures.
So yes, that's true. Well, in fact, the patient had really developed a fracture. This is seen through an X-ray examination and shows that the patient had developed a compression fracture of the third lumbar vertebra.
Oh, so you're here again. And I can sense your levels are too high.
Ha, 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 ha.
I need to stop producing hormones.
ACTH levels are dropping, huh? Okay, I'll stop secreting hormones.
And so, adrenal cortex stopped in producing cortisol and androgens.
Okay, so do you remember your hypothalamic pituitary adrenal axis? So in this case, what do you think will happen and what is the effect on the body?
Doc, I'll just try po. So, I think po, Doc, due to the increasing levels of exogenous cortisol, ACTH production as well as CRH is depressed. But the problem here is ACTH also stimulates the secretion of adrenal androgens, which is converted peripherally into estrogen for females. On the other hand, production of progesterone, a precursor of cortisol, is also decreased due to the decreased stimulation from the ACTH. So both of these hormones are essential in maintaining the normal cycle of menstruation. With this po, Doc, I think menstrual cycle of the patient may be irregular.
That answer is well thought of. Yes, Miss Pelobello is right. Decreased secretion of ACTH affect other hormones as well. Okay, class, can you think of other effects of too much cortisol in the body? For example, you're exposed to too much stress. What changes in your skin do you usually see?
Doc, is it pimples or comedones?
Yes, Miss Baidiango, you're right. Can you please explain how too much cortisol can produce pimples?
I think, Doc, this is due to the stimulation of cortisol to the sebaceous glands to produce more oil. So with the increased oil, the production of our pores, oil clogging or trapping of microorganisms is possible. This clogged pore will be inflamed and eventually produces pus. And this is the pimple that we see on the surface of our skin.
Correct. Are you planning to be a dermatologist someday? To add with this, too much cortisol levels in the plasma can cause hair growth patterns that is usually observed in men or hirsutism. This is due to increased dihydrotestosterone in the circulation, which stimulates the hair follicles to increase their growth.
So normally, androgens are bound to binding proteins in the plasma. But due to the increased cortisol levels, cortisol has a tendency to occupy the binding sites for androgens. So this causes the androgen levels to increase and be reduced into dihydrotestosterone form. The doctor decided to remove dexamethasone from the treatment plan, and the patient was monitored closely for her to follow diet and exercise rigidly. Of course, because of that, 2 months later, the patient's general condition was improved, in which her fasting plasma glucose was down to 98 milligrams per deciliter. Do you see how important it is to see to it that your patient complies to the treatment? She was then advised by her doctor to be placed on a low corticosteroid regimen in addition to levothyroxine and estrogen. Her doctor put a strong emphasis on not to change the dose of the medicine and to see her endocrinologist immediately if she became severely ill or if she will be needing surgery. And for the past 3 years, the patient remained asymptomatic.
So there you have it, class. Based on her clinical findings and symptoms, the patient presented with Sheehan'S syndrome. This is a condition that affects women who lose a life-threatening amount of blood in childbirth or who have severe low blood pressure during or after childbirth, which can deprive the body of oxygen. In our case, this decrease in blood pressure is triggered by severe diarrhea and vomiting that led to decreased circulating blood volume and decreased oxygen perfusing capacity of the blood. Hormone replacement therapy was started. However, with her excessive intake of corticosteroid, 4 times the prescribed dose, she eventually developed Cushing'S syndrome, which characterizes an increase in the cortisol in the circulation that further led to a cascade of symptoms. Corticosteroid was then discontinued. The patient improved and was started on low corticosteroid therapy, and she was advised not to change any of her dose and to consult her doctor immediately if she experienced any changes.
Doc, ito po ba yung kwento kung ba't Sheehan yung pangalan niyo?
Sheehan! Anak, kakain na!
I'm in the middle of a class!
Tama na nga yan! Binikwento mo lang naman ako eh!
Yeah!
You have all you need. I'm gonna sweat and bleed. Yes, I will. At any moment, place and any time, I'm always open. It's never closing time. Not gonna let you down. I'm gonna go all out on you. I'm gonna give. I'm gonna give. I'm gonna give. I'm gonna give you all I got. I'm gonna give. I'm gonna give. I'm gonna give you all I got. You all I got. I'm gonna give you. I'm gonna give you. I'm gonna give. I'm gonna give.